Well, hi everybody. This is the second individualized talk that we are going to do, and for us, it's a big pleasure to have Dr. Avram Manea, which is someone that we know. I think 4 years ago, no, that we have started together.
Hello, hello. Very happy to be here. I'm honored to be here talking to you, and also very happy because this has been one of the best collaborations so far in my career. So I'm very happy to have met you and to work with you. It's more than 4 years, I guess. It will
Probably.
in a few months. I think we'll be close to five, if I remember correctly. So yeah,
Yeah.
quite a few years.
Yeah, and also because it's someone that is bring us lot of knowledge because always share. So he is one of our key opinion leaders and also a clinical advisor for us. So it has been helping us a lot to develop a system. Um, so I forgot to tell you that you live in Cluj, Romania.
Right?
Yes, and you are a maxillofacial surgeon. And so we already said that we started about 5 years ago. Do you have any idea how many patients treated with our solutions?
I think we're somewhere at about 50. At first, I was like in any topic, in any new medical device, I would not say skeptic, but I would say cautious. So at first, I only wanted to do two or three cases in the first year, for instance. But then seeing how well everything works and how well we can work together, the number of cases grew and is continuing to grow exponentially.
Okay, so we decided to divide this on three sections. Okay, three different sections, which is dental rehabilitation of very atrophic cases. Then we go directly for facial reconstruction, which are much more complex cases. And finally, something that we have started a few time ago, but it seems that we are doing very well. It's the custom-made minimum invasive orthognatics. So, um, about dental rehabilitation, you want to make some kind of comparing with other systems for solving this, and when to choose one and when to choose the other solutions.
Sure. Let me share my screen with you. I have a short presentation uh, prepared. We can talk about this for many, many hours, but I will try to keep it really short. Um, so, can you see my screen right now?
Perfectly, perfectly,
Okay,
yeah.
thank you. So, uh, I'm a maxillofacial surgeon. Of course, I do a lot of surgeries, and in the private practice in local anesthesia, I do a lot of implantology cases. And I was kind of frustrated because there were cases where none of the actual techniques, the present techniques, were able to solve the problem. We did a lot of bone grafting, did a lot of soft tissue grafting, so this is not something that was not familiar to us. But even so, there were some cases that could not benefit from bone grafting, or if we could do bone grafts, we needed a lot of time and a lot of risks. In these cases, uh, we had no actual solution. Of course, we did a lot of harvesting, bone grafting from the iliac crest. The results are good, but you know that the bone atrophy is the graft atrophy is quite intense and quite quick. So we use the biomaterials in combination with these grafts, but still there was the problem of time. The patient would have the final rehabilitation in at least 1 year. So whenever we have normal cases that can benefit from bone grafting, we use the conventional methods. But unfortunately, there are cases where the classical methods, whatever kind of grafting method you might imagine, will not work. So in these cases, we were searching for a solution to replace the normal implants. It was it's easy to look back to look back in the history of implantology. And since I teach implantology to fifth and sixth year students in our university, um, I told them about knowing your history, knowing the certain science history, and I was also presenting to them the subperiosteal implants, the old ones. Of course, everybody knows the major disadvantages, the the time it took for them to be ready, the quality of their anchorage, and the invasiveness and everything that you can think of. And obviously, this is one of the reasons, or these are one of the reasons why they're not used anymore. But I was thinking that having the CBCTs very available to us, having the osteosynthesis techniques that are very popular nowadays, maybe somebody would design a system that could replace these old implants. And I was very happy to find out about you. So this is how it started, and uh, these are the cases where we use this type of custom structures, custom implants. For instance, in scenarios like this one on the left, you can see where the tooth would have normally been, and you can see an immense loss of bone, especially the vertical aspect of the bone, which is impossible to augment by classical techniques. Or in the right, where we don't have a mandibular canal, we have a mandibular ridge. Or a ditch, sorry. We have -1 millimeters of available bone. Okay, so in these cases, I cannot come up with some kind of bone augmentation technique that
Yes.
is predictable and safe and has at least 50% chances of working. And I don't want 50% chances. I want 97, 99% success rate. We did a lot of biomechanics, bioengineering. We have a lot of research in the field, and one of the articles that we've published with a lot of citations is an article regarding biomechanics in oral implantology. This was published many years ago, one of my first studies. But from that moment on, I understood that in oral implantology, we were dealing 50% with biology and 50% with mechanics. Anybody that wants to have success in the field, I think that must understand. I think they must understand the principles
Biomechanics.
of biomechanics. You
Sure.
cannot have success without it. So the conclusions of this longer article was that you have four very important parameters from the mechanical point of view in implantology regarding the length, the width, the angulation of the implant, and the crown to implant ratio. Uh, our study showed that if one of these parameters is affected, we can still have clinical success. For instance, short implants work. Everybody knows this. Narrow implants work. Again, everybody knows this. Uh, High angulation also works. The all-on cases that everybody is very fond of doing nowadays. You have at least 30 degrees of angulations, if not more than that. Okay, but if you have more than one parameter that is affected, you will have failure. If you have three parameters or four of these parameters affected, then failure is not a possibility, it's certain. So this is why, for instance, I'm not a very big fan of zygoma implants. They work, but due to biomechanical reasons, I'm not talking about sinus implications of these implants. But just due to biomechanical reasons, I'm not a big fan. Also, we have other options like vertical bone augmentation. Problems with the soft tissues. It's difficult to obtain the enough periosteal volume to have a predictable result. There are other options like sinus lifting. Everybody does it. It's very safe, very easy, very predictable. Or lateral bone augmentation. Again, very predictable. But unfortunately, as I said before, many cases cannot benefit from these solutions. Again, a lot of experience with biomechanics. This is a prototype of an implant we patented many years ago, which opened our eyes into this field of biomechanics, as I said before, and element testing and uh, everything that involves mechanics in oral implantology. This is the actually the first case we ever did together. I think you remember her.
Yes.
Uh, a very nice young lady with extremely severe atrophy. Due to the position of the nerve, due to several biological considerations, and not to forget the patient's wish to have teeth as soon as possible, I told her that I just found out about this producer from Portugal that seems to be very promising. You had very good references from Dr. Gheorghiță in Bucharest, and I was more than curious to see how this works. But I insisted in telling her several times that is something that this is something that I have never used before. Although the products seem great, although the idea behind the whole concept seems great, I had no experience before. And instead of her not being sure, she was actually very happy to be the first one to get this type of implant. So we went forward with everything, and this is uh, this is the case, our oldest case, close to 5 years of follow up in the following month. I just saw her 2 or 3 months ago. She's a very committed patient. She understood the importance of frequent checkups. At least once a year, she's coming to us to just say hello and see how everything is going. And I think this is vital in any type of implantology, especially in these complex cases. And I was glad to see her a few months ago and see that everything is going great. Uh, a lot of other cases, like you can see here, this is an older case with old implants that have failed. They got fractured, all of them, as you can see in the upper right image. And after removing them, the vertical dimension, even if in theory we could have went with another sinus lift, the vertical dimension and the crown to implant ratio would have been very, very problematic. And seeing how she managed to fracture the implants, uh, using implants with even worse biomechanical properties would have been a real problem here. This is the design of the implant, the digital design. Thank you for all your help with these digital designs because I can only imagine it takes a lot of work. I mean, of course, we are involved a lot in this, and we are very happy that you always listen to our requests regarding the design of the implant. But I am aware that drawing all these lines and all these positions and taking care that none of the screws hit any of the anatomic elements and everything is not easy. So thank you for all your effort in this.
Also making mechanical simulations for each case. We always do.
And showing the study that we've published before regarding the fine element analysis, I can really understand how that works, and I know that is very valuable for the future success. because, as I said, the follow-up of these structures is interesting. The long-term follow-up, um, because there are for the for the normal implants, everybody uses the ISO standards. 14 801, I think it's the standard for fatigue testing in dental implants. But for these custom structures, it's more difficult to get testing done. And of course, it's impossible for you to produce an actual implant copy for every implant you produce and break it and see how it works. But the digital testing is very relevant and very helpful. Um, so this is a case where we use the intraoral scanners. Most of the cases that we do are involving intraoral scans. Another case, one of the first cases with the old implant designs, the X-rays, and again the scans. This patient became a friend. We worked on this case, and then we worked on other aspects regarding his job, and we actually became good friends. One of the worst cases is here. Here you can see the nerve. It's on the bone. It's not in the bone. It's on the mandible. Again, I do not know any kind of bone augmenting technique that could have worked here. I mean, you can do something like a nerve lateralization, but you still have 4 millimeters of bone left, including the basilar. So again, really do not know how to treat this patient, not even with a removable denture, because the landscape of the crest, the inferior crest, was negative here. Uh, the muscles of the floor of the mouth and of the cheeks were above the bone. Their insertions were so high compared to the residual crest that not even a removable denture would have worked for this patient. And the patient was 50 something years old, so not very old, and she definitely wanted some fixed solution, no removable denture. So we said, okay, this is the only solution that can be used here. You can see some intraoperative images, um, where the alveolar nerve uh, has its final branches, the mental nerve and incisive canine nerve. Very impressive to see this anatomy. Uh, the implant here and the provisional the next day after surgery. Uh, 1 year after the surgery, the patient came back for the final restoration. I'm really happy to see the aspect of the soft tissues, because we did a lot of grafting before the surgery. The soft tissues are in place. I know they're not looking perfect, but it's impossible to have perfect soft tissue aspects when you have absolutely no bone above the nerve. So it was kind of uh, it was a very difficult and beautiful in the same time case from a surgical point of view. And this is the aspect 1 year after surgery with the final restoration. The patient was very, very happy. Another case here, you can see the aspect of on the upper image, the aspect before surgery, and during the first surgery to prepare the implant for the custom implant for the maxilla. Everything was removed from the lower arch, and the upper arch was grafted. The tissue here was very, very thin, the soft tissues, and we grafted everything from one part to the other to make sure that we have a good clinical outcome and success. The new types of guides on the upper right, very useful, very, very precise, and some images from the episode of preparing the sites for the connectors. The image with the implants in place, and the provisional the next day. This is another case, another older case with the old implant design. Um, I just kept this case here for everybody to see that it is possible to use the classical techniques. You don't always need to use the digital scans, the intraoral scans. You can also have good results with the classical techniques, and many other cases where you can see how thin the bone is and how little bone volume the patient has. Again, a classical impression using the analog techniques. Also, I was saying that we know that there are other options. We use all the other options. This is a case where we could have used a Ramos frame implant. Have you seen this type of implants?
Yes, I did. In reality, in France, they were very popular when I studied there.
Hmm. So we also have a lot of experience with these implants, and in the past few years, since we have the possibility to print the mandible, it's much easier to customize this standard implant for the patient's mandible, which reduces the risks and also reduces the surgical times by a lot. Uh, Here, obviously, you will have a removable denture, but with really good stability. So the patients are quite happy. Their average lifespan is about 10 years. But what happens when they fail? And they will fail after about 10, maybe 15 years if you're lucky. The bone that's left is almost non-existent. The fracture risks are quite high. And again, the patient only gets a removable denture. So this is a good alternative. But when we discovered these customized implants, the Ramos frame implants are becoming more and more, let's say, obsolete, and we use them very rare right now. But they were great. They were good. They worked. Only medicine evolves, technology evolves, and with these new custom implants, uh, we don't really need to use these Ramos frame implants anymore. This is the alternative design for the Ramos frame implants. They were presented as a comparison. I'm not going to insist on this design too much. And these are again images from the surgical from surgery and the postoperative 2D imaging. Many cases with the same issues and with the same severe bone atrophy. All implants for removable dentures that have failed and are now replaced with a new type of implants. A very nice case, a case from Italy. She came to us because she could not find a solution uh, for this very large bone loss, and she did not have a gingival, a gummy smile, a high gingival smile. Um, and when I saw her, I knew that we have the perfect solution. I also told her about osteodistraction. This is another case, and I showed pictures and explained how this works. Distraction osteogenesis is very popular and very helpful. But in her case, it would have been impossible to apply because of the many months that she needed to stay with the distractor in the oral cavity and right on the midline. So this is the solution. We applied the provisional the next day and the final restoration in 6 months. Of course, with a gummy smile, the aesthetics wouldn't not have been perfect here, but comparing to all the other solutions, this is by far and by a big distance. When I say by far, the best solution, especially when she did not have a gingival gummy smile, she was very happy with the results. Other cases where we apply all the guided technology for the lower arch in this case, and the guided technology for the upper arch with a customized implant, an all on five case. the provisional the next day. Again, a very happy patient, and many other cases. I'm not going to insist on these cases anymore because you would get bored. But I think that this is a very good solution for severe atrophy cases.
Okay, amazing. In reality, um, so much more problematic and defining it's to go to do cases of facial reconstruction, because this we have to maintain the device inside the tissue, and the facial tissue it's very thin, and but even so we have done some cases with lots of success, but these are cases that I discuss it always with you, because we need to plan. Not it's not only to plan the device, but also to plan all the things like incisions, where are going to place it, in how many pieces we should do it. Please enlighten us.
Okay, so yeah, you're right. Compared to the atrophic ridges, these cases are much more complex from many points of view. Of course, even the planning is much more difficult, and obviously the surgery is much more complex. Um, First of all, you have to know your alternatives, as you said before, with the atrophic ridges. We know what our alternatives are. We do these reconstructions, and we used to do this reconstruction even before we had access to these custom structures. For instance, this is a case that was operated by Dr. Fodor, which is a top plastic surgeon. Very good results in all his interventions. Um, and these are some images from surgery and from after. Good reconstruction, good aspect, but we have to keep in mind all the disadvantages of these techniques, like the harvesting site, the fact that you need two teams, the risks of having all sorts of infections in both the donor and the receiving sites, and also the time it takes for the patient to have a final rehabilitation. If you take into consideration the teeth, the implants that need to be placed and need to heal, the patient will have their dental arches reconstructed in at least 1 year if everything is going fine. Uh, this is a very beautiful case done together with Professor Anishore, which is one of the closest collaborators and one of my mentors. And he believed in this project with all the customized structures a lot from the beginning. This is a case that had uh, fibrous dysplasia. She was a teacher and she was starting to have double vision, and this is why she came to Dr. Onishore for this surgery. After the biopsy, he performed this excision and this large excision of the maxillary bone, and made this reconstruction of the floor of the orbit. We have the results from the pathology department. We have a bone scintigraphy to make sure that we don't have any other bones affected in the body by this fibrous dysplasia. But this is the aspect of the patient. And Dr. Venshore came to me and asked me, okay, what solutions do we have here for the reconstruction? And I told him, you know that customized structure here would be perfect. Uh, we decided to keep the floor of the orbit because her vision was perfect, no double vision. Everything was great from the eye point of view. but the aesthetics needed to be improved because she could not teach like that. She could not live like that with a big hole in her face. Um, the teeth for her were at that moment not that important, but this is let's call it a big added bonus. The fact that she could have gotten the teeth immediately after this surgery. Images from the surgery. We prefer to insert this 2D image in this presentation because it's extremely nice. You can see it very nicely here. Of course, we take CT scans for all the surgeries afterwards as well. And the patient, a few months after surgery, the teeth are there, and she's very happy that she can chew on both sides. And the exoral aspect, a good few years after surgery. So immense improvement. Another case with a basal cell carcinoma, you can see the soft palate moving here, very impressive. The CT before surgery, he had some surgery somewhere, I don't know exactly where, I cannot remember, it's not important actually, but uh, this is an evolution of the disease. It appears that in the first surgery, the tumor was not removed completely, and after having the surgery to remove the whole tumor, the defect was huge. Um, Here, you cannot use any flaps to close the defect. So, Rui, we discussed to have an epithesis, and you provided a very good anchorage for this structure. These are the first impressions, classic impressions and digital impressions for the epithesis. This is the first version of the epithesis, and now we're trying to work on an improved form, both from an
Vietnam.
aesthetic point of view. Yes, yes,
Yeah.
this was done in Vietnam. And now we're trying to get some better aspects, a new epithesis with a little bit better aspect. But this is functional. This is great for the patient. He was very happy with this epithesis and not having a hole in his face, an actual hole. These are the new scans, and we're working on this epithesis. Hopefully, we will have a result soon. Um, Here, the patient. This is another case, a young patient with odontogenic keratocyst. We needed a large excision. In these cases, you have the options of using a fibular flap or just a bar or reconstruction bar or a reconstruction bar with iliac bone grafts or many other possibilities of combining these methods. But the patient was also presented with this custom possibility, this custom reconstruction, and he was very interested in seeing how this works. And we presented to him the design and all the advantages. The major advantage, from my point of view, being that the lowest number of variables you have, the higher the chances of success are. And with these structures, there are many variables that are actually removed from the equation. Um, and this is what I think, and this is what I thought from the beginning, and I most likely will think in the future, that the fewer variables you have in a surgery, the more predictable and the better the results are. Please correct me if I'm wrong.
Yeah.
Um, and this is the CT scan after surgery, images from the surgery. The next day after surgery, you can see a perfect fitting of all the structures to the remaining bone. And 1 year after surgery, with a perfect facial aspect, perfect function, a very, very happy patient. And exactly like this, we have two more cases that are underway right now. Hopefully, we will be able to perform the surgeries in January or at least February. This also depends on the patients, but you gave us the design, and we reached a final version of the designs. I'm really happy with all the attention that's been paid for every screw to protect the nerves and for the connectors that are taking into account the position of the future teeth. This backwards planning is, from my point of view, absolutely mandatory in any implant case we are discussing, either being it a simple implant or a full arch restoration, or even for these complex restorations where we need to reconstruct the whole mandible, not only the teeth. But even here, the fact that you start with the teeth is very, very helpful for us in the future. Another case with a bar. Both this case and the previous case were cases with ameloblastoma. This is another ameloblastoma case that had surgery many years ago, but the aspect is not perfect. The facial aspect is not perfect. Also, the patient does not have teeth on that side, so she decided that she wants something more comfortable, something better, and this is why she opted for this customized reconstruction, and she was very interested in seeing the results. I'm sure she will be also very happy with the final results of the restoration. Another case, a very recent case, surgery was done by my colleague Dr. Zermure, and he's doing a lot of vascularized clefts. And this is a very good comparison because these cases will be the surgeries will be quite close to each other from a time point of view, from a time perspective, and we can compare the results over time. Ameloblastoma again with a fibular flap. You can see the reconstruction here and the the aspect before surgery. I mean, during surgery, after removing the mandible, and after placing the flap during the anastomosis of the vessels and the CT scans after surgery. So we are aware of all these techniques. We have experience with these techniques, and still we are looking to these custom structures as a very, very good alternative solution. Again, removing many, many variables. This is one of my favorite cases. This is a case that has been treated by Professor Bran, my mentor, for many, many years. Uh, I know this patient from when I was a student, actually. He's a patient with a medial face cleft, very rare cases. Very few of these patients reach maturity. He had Lefort 3 osteotomies to get an advancement of the mid face, Lefort 1 to advance his maxilla, and many, many other cosmetic surgeries to get a decent aspect. And I think that this is not a decent aspect, this is close to a good facial aspect. But the thing is that after all the surgeries and with his very poor bone, there were no actual solutions for him to get teeth. And of course, he wanted to get teeth, and this is where I also got involved in doing this reconstruction and giving him a chance to have a normal life with his teeth. This is the first provisional restoration with this custom implant supported structure. And this is the second provisional restoration. He will get a final restoration soon. Clefts, you see a lot of clefts in our field. And normally, all these cases end up as adults to have hypo development of the maxilla. We have a problem from a sagittal point of view and from a transversal point of view. Normally, they would have to undergo all the steps of orthognathic surgery, but there are patients, adult patients. This patient here is about 40, which did not want to undergo all the steps of orthognathic surgery. and she still wanted teeth. And this was the only solution that we could think of, because you can see on the image on the left this huge sagittal defect of his maxilla. Absolutely no other solutions would have provided us with the capability to come up with such a big cantilever. Even if we could have placed implants, if he would have had bone, which was not the case, but hypothetically speaking, if we would have had enough bone here, we still would have had a big biomechanical issue regarding the cantilevers, the angulations, and the crown to implant ratio for this restoration. And this is the provisional restoration immediately after surgery. And again, a very, very, very nice case. A young lady that had this ankylosis on the left angle of on the left TMJ. She underwent osteodistraction of the left side of the mandible, orthognathic surgery, bimaxillary surgery, but now she's left with this big defect. She's in the fashion industry, in the makeup industry, and she's very frustrated with this severe facial asymmetry. We talked to her about the option of printing a new mandible angle. Also, we gave her other possibilities like iliac graft, but this is what she wanted, and this is what we gave her. This is on the right an image during surgery, and this is immediately after she woke up. She was already smiling. She was very happy. Here, there is the discussion about the TMJ that I personally think that needs to be replaced, but she is so happy with the aesthetic result right now that we need to let her think about it some more. Right now, her only issue was regarding the,
Aesthetics.
the aesthetics, yes. But I will insist on reconstructing the TMJ as well. Of course, now she is upset that she has this little scar here, and this is her major concern right now. Not the TMJ, but this little scar here. And I told her that if this is your biggest issue in life, then you're very happy and very lucky.
Too.
We will take care of that as well. This is from when she was a child. This scar, but we will take care of it. Just let the edema pass.
No.
And 2 weeks after surgery, very very happy. You can see the huge smile on her face and on
Amazing.
our faces as well, because this is the most important thing in our job, seeing the patient smiling again.
So, and finally, our last passion. We have been doing this custom made minimal invasive orthognatics. We are still pushing a little bit some strings, no, because we
Mhm.
like to do it perfect. So we are still developing. We are hearing you. We are working together on this, but it seems very promising, no?
Yes, the results are not good. The results are impressive, and I thank you for your help in the field, and also for your knowledge in the field, the fact that you have some experience and share your experience with us. This is very valuable. And also thank you for the fact that you keep in mind and you take account of all our ideas and the critics, because this is the way something like this can evolve, and this is very very helpful for us. So let me share some examples of orthognathic cases. Just 1 second. I think that you will be able to see it right now.
Yes,
This
we are
is
seeing.
this is the first case we've done together. Um, a patient with a class 3 and open bite. This is the design of the plates and of the osteotomy guides. Very very helpful. The models before and after, the guides that are applied in the oral cavity of the patient, very very precise, because they have two support. we still use the splints to make sure that we have both of the information from the splints and from the plates, from the custom plates.
It's
This
always
is
good to have a plan B.
yes, and it's sometimes if you use plan A and plan B during the same time, you reduce the risks and
Sure.
all the possible complications to the absolute minimum. And I'm very happy with this combination for now. Maybe in the future this might work splintless. Uh, and the final results after the osteosynthesis and the patient a few days after surgery. You can see the minimal facial edema, very very little trauma compared to the normal orthognathic techniques. Also, no risks of having contact between the screws and the roots of the teeth, and not having the need to place the regular plates that we place, because normally we would place two plates on the lateral aspect of the preform aperture, but also we would place two plates on each side on the zygomatic alveolar buttress. So this means less invasive surgery at the level of the maxilla, and even better stability, because you can predict the positions of the screws where the best bone is. And I asked for this image, and thank you for providing it. Here we can see the comparison, a very good and very helpful comparison of the CT scan after surgery, so the control CT scan and planning, the initial planning. You can see it's almost perfect. Of course, the plates are extra, but they don't matter. But for the important part of the maxilla, the position is close to perfect compared to the planning. Uh, our biggest concern in the classical techniques of orthodontic surgery are involving the positioning of the maxilla. I mean, we can come up with a perfect plan before surgery, but the repositioning of the maxilla always relies on the TMJ, which is not a fixed articulation. As you know, it's a very complex articulation. So there might be slight errors in repositioning of the maxilla with the classical techniques. But with these plates, you said that the corresponding percent was about 99%, if I remember
Yes,
correctly,
yes, yes.
which is absolutely amazing. Absolutely amazing. Uh, Besides all the other advantages regarding the minimal invasiveness of the surgery, the time of the surgery, and all the other aspects that are obvious, this superimposition of the CT, the final CT, with the original planning is impressive to me. This is what I love the most about this technique. Another case, this was done recently, a few weeks ago, um, with a class 3, severe class 3. You can see that the facial aspect is seriously impaired by this anomaly. This was a surgery first case. She had no prior orthodontic treatment, but she will have the orthodontic treatment starting from now. And hopefully the final result will be available in a few months. These are the plates, the guides, the cutting guides, and the screw guides. Um, and a few images from surgery, maxilla, uh, with exposing of the bone, less exposure than is normal needed for this kind of surgery. Osteotomy of the mandible. Okay, and I think it's getting blocked because it's a 4K film and it's
Yeah.
a lot of information for the internet to process. Uh, Okay, I'm not going to insist on this anymore because it might get blocked or not. I just wanted to show you the plates. The cutting guides for the mandible, and now the cutting guides for the maxilla. The maxilla is completely mobile, completely, of course, meaning that it still has some soft tissue insertions and the palatal arteries. Without them, we would have necrosis of the maxilla, but you can see that the range of mobility of the maxilla is quite high. And then the plates that give us the perfect position. Again, as I said, using the splints for extra safety, but they're a formality, just letting us know that we're doing a good job and we're in the right position. Now the split of the mandible, taking care of the nerves on each side, splitting the mandible on the right side as well, blocking the mandible versus against the maxilla, and the osteosynthesis, where you can see the plates perfectly fitting into place. So very, very helpful and very quick system. Pictures with the osteosynthesis, you can see how close you can get to important anatomical elements without any fear, and how well we can get the fixation of the maxilla, avoiding the roots, like the roots of the canines here. You know that the risk of touching the the apexes of the roots is quite high in orthodontic surgery, and the consequences are obviously unpleasant. And 2 days after surgery, where the edema is the maximum, and 2 weeks after surgery, she came for us to check her up and to remove some of the sutures that were bothering her. And again, 99% correspondence between the position of the maxilla in the planning and in the postoperative CT. I was thinking, Rui, what's with the red here, but I remember that there were some small fractures of the sinus wall because it was very, very
Very thin.
thin,
Yeah.
very thin, incredibly thin. But other than that, perfect correspondence between the preoperative planning and the postoperative CT. Again, as I said before, this impresses me the most. Okay, so this was the orthognathic section as well. Very, very good results, very promising results. I really hope we can do many, many more cases like this together.
Sure. And we were about to have an individualized talk, and we went up with a masterclass, which was really, really amazing. I just have to congratulate. It's an amazing job. It is impressive for most of the viewers, and I'm sure that everyone is delightful to see this type of work. After this, we are going to have two QR codes where people can scan it and where people can find Dr. Avram Manea for if they want some help or if they have cases with patients that need his help, so they can scan it and find out the sites. Um, Again, thank you. It was really amazing. I was delighted to see it. It was really, really impressive. It was a masterclass. We have learned so much with you today, okay?
Thank you, and thank you for this amazing work that you're doing for us and with us. Uh, I was searching for a long time to find somebody that could provide us with these structures and with these products. But what you provide is above any of my expectations. So thank you very much for that.
Thank you. And thank you, everyone. So, we will soon say when we have the next individualized talk. Thank you, Dr. Abram. Okay?
Thank
Goodbye.
you. Have a great evening, everybody. Thank you. Bye
Okay.
bye.
Thank you. Bye.